Hello, just
Hello,
testing
welcome
to
to
see
E&M
how this
Basics.
sounds.
My name is.
This webinar is going to focus on office visits 99202 through 99215. Evaluation and management, or otherwise E&M services, provide physicians with the opportunity to evaluate and manage symptoms, illnesses, and disease with their patient present. The reason for the visit is always the primary diagnosis for any E&M service. So new versus established. If a patient hasn't seen the provider within 3 years, that's a new patient. If they have seen them, that is an established patient. And it's based on the physician, which or other qualified healthcare provider in the exact same specialty and subspecialty who belong to the same group practice within the past 3 years. So when the guidelines state physician, that means anyone in the same specialty and or subspecialty in the same group. If a physician or an NP or a PA is on call covering for another physician, that patient's encounter would be classified as if the patient saw the physician that is not available. When an APP or APA are working with physicians, they are considered working in the exact same specialty and subspecialty as the physician. Documentation. Although history and exam are no longer used to determine the E&M level, it's very important because this is what helps support the differential or rule out diagnoses and medical necessity. You can use either MDM or time when determining the level of evaluation and management. Most of the time, MDM is used. If a provider documents both, you can use the one that supports the higher level. Most of the time, the MDM will support the appropriate level. There are visits where time may be the better option. For example, if a patient has multiple acute illnesses being addressed at one time. Problem addressed. So a problem addressed is the condition or problem that the provider spends time treating, discussing, and making a treatment plan for with the patient during that visit. If the provider mentions a condition such as diabetes and states that this is managed by the endocrinologist, that problem would not be counted as a problem addressed by the physician at that visit. If you're using time to determine the level of service, it is the total time on that date of the visit. This includes both non-face-to-face and face-to-face. It includes time regardless of where the physician is located as long as it is the day of the encounter. If you are using time to determine the level of service, it is the total time, again, on the date of the visit. This includes non-face-to-face and face-to-face. The non-face-to-face time would be for things such as the provider going over previous notes, the patient's past medical and or social history, etc., things like that. The face-to-face time would include things such as obtaining a medically appropriate history, performing the exam, counseling and or educating the patient, family, caregiver, ordering meds, ordering tests, procedures, referrals, independent interpretation of tests, and documenting in the medical record. Time is typically not used often when determining the level of service. When using MDM to determine the level of service, there are 4 types of medical decision making: straightforward, low, moderate, and high. On the MDM table, you have 3 columns: the number and complexity of problem or problems that are addressed during the encounter, the amount and or complexity of data to be reviewed and analyzed, the risk of complications and or morbidity or mortality of patient management. The number and complexity of problems or problems that are addressed during the encounter is often referred to as COPA, complexity of problems addressed at the encounter. In this section, you have what I call buckets that things can fall in. On this slide, you will see all of the buckets listed in this column on the MDM grid. The AMA E&M guidelines will go into very detailed definition of what each of these are. The link will be provided at the end of this. When coding E&M services, it is very important that you review the AMA E&M guideline packet to understand what each of the categories mean, because sometimes the words that we know have a different meaning with AMA when AMA is thinking of the definition in clinical. For example, stable to us may mean not changing, not getting worse. Per AMA, when they use the word stable, it means a patient who is at their treatment goal. For example, if a patient with persistently poorly controlled blood pressure is normal for the patient, but that is not at the treatment goal set by the physician, then that means that the patient is not stable because they are not at goal. Data. This column focuses on tests ordered, reviewed, independent interpretation of images, and or discussion with another provider. You need to pay close attention to how to read this column. You can see there is category 1, category 2, and 3 with bullets under each that make up the category. We will go further in detail with this later on when we review the MDM table. The third column is about risk. For this column, it is important to understand that this is the risk of the treatment plan, not the clinical risk of the patient's condition. For instance, you see under moderate risk, there's prescription drug management. Think of it like this. If you are prescribed a medication, there's always a risk of possible side effects or allergic reaction. So this is how you need to think about risk when reviewing this column on the E&M, when selecting E&Ms. Here's the actual MDM table that is used to determine all levels of evaluation and management. On this slide, we have taken everything that we've reviewed on the previous slides and put them all together into one. Here you can see how the buckets are divided up in each column and row. Let's review how to read the data section. Remember I mentioned you have categories 1, 2, and 3 with bullets? I call them buckets. That makes up each category. If you look at limited, see where it states must meet the requirements of at least one of the 2 categories, but also under category 1, it states any combination of 2 from the following. So, and you can see that it's ordering, reviewing of each unique test. A unique test, think of it as a CPT code. So each test with a different CPT code, that counts as a unique test. Remember, if you are ordering a test, you cannot get credit for both ordering and reviewing because AMA states that if you are ordering the test, it is assumed that you are going to want to review the results. I can't stress enough the importance of reviewing the AMA E&M guideline packet. I would review this at least once a month. to make sure, because you may read it 10 times and you do not get any new information. The 11th time that you read it, there may be one part in there that just clicks different in your mind. So next we are going to look at a chart example and then level it by using the MDM table. So a 28-year-old female returning to the office today with complaints of right lower quadrant pain and heartburn. She has a temperature of 101.2. The provider performs medically appropriate history and exam. Provider orders abdominal ultrasound to rule out appendicitis. The ultrasound shows patient has mild appendicitis. Provider prescribes antibiotics to treat the appendicitis and hopes to avoid surgery. Now let's look how that will look on the MDM table. So acute illness with systemic symptoms, because it's abdominal pain and a fever, would score it moderate in COPA. They only did an ultrasound, so that's one unique test, so that would be minimum in data. And they gave a prescription, which would be moderate in risk. We only need 2 of the 3 columns. So if you look across at the rows, moderate, we have 2 of the 3 columns. So we would score this chart as moderate, which would be a level 4. So now let's put it all together. You put everything together as we just did on the previous slide with the MDM table, and that's how you determine your level of service. Remember that the primary diagnosis should always be the reason for the visit. Then ask yourself, does the documentation support both the level of service and diagnosis that I have assigned? Don't forget the why. I always say when you're a coder and you're at the end putting it all together, you need to become a toddler and ask, but why? But why? About everything. Because you need to be able to support your levels and the documentation in the medical record. So why is the test being ordered? Why is that a differential diagnosis? Why are you giving the antibiotic? Because everything needs to be there to support medical necessity. CMS states that medical necessity is the services or supplies needed to diagnose or treat an illness, injury, condition, or disease, and meets accepted standards of medicine. For example, you would give an antibiotic for an infection, you would order an ankle x-ray for ankle pain, but you would not order a chest x-ray with a diagnosis of ankle sprain. And a patient diagnosed with a heart attack would not have the same level of service as a patient that is there for an ear infection. Why is documentation important? Accurate documentation is very important for correct reimbursement from insurance. That is what the insurance company uses to validate medical necessity and payment. The documentation is the only information that a provider has to protect themselves and the healthcare facility in a malpractice lawsuit if that were to ever come up. Well-documented records are very important and provide easy transitions from provider to provider in the care of a patient. Documentation also helps with patient safety. Accurate documentation prevents misdiagnoses, medical errors, unnecessary procedures and tests, and makes sure patients getting the appropriate care. Healthcare facilities use documentation to track performance metrics. They look for trends and improvements in workflow or other areas in the practice and facility. So you see, documentation is not just about being able to find wording and checking off boxes on the MDM table to assign levels of care. It's used in so many other ways. So when reviewing documentation and assigning E&M levels and diagnoses, treat the medical record as if it were your own. All of this is so important to establish a good working relationship between the medical coders and the providers. Here are the resources that I mentioned. The first one is the AMA E&M guidelines. The second one is an excellent tool to use when you're doing E&M coding, and it's the ASAP FAQs. I hope this webinar was very helpful and you learned some information. If you have any questions or if there are other webinars that you would like to see information on, please contact us at info@advancedcodingexperts.com. Thank you for listening. I hope to see you join future webinars.